Welcome back to our exam prep podcast. Today we are tackling malaria. Dr. Joshi, could you start us off with a crisp, exam-friendly definition?
Malaria is a protozoal disease caused by Plasmodium species, mainly Plasmodium falciparum and Plasmodium vivax in India, transmitted to humans by the bite of infected female Anopheles mosquitoes. It presents with fever and systemic symptoms and ranges from uncomplicated illness to severe, life-threatening disease.
Which mosquito genus transmits malaria? And which two Plasmodium species dominate in India?
Anopheles is the vector. The big two are Plasmodium falciparum and Plasmodium vivax.
Let us move from recall to explain. Could you outline the life cycle and why it matters for prevention?
The parasite has two hosts. In humans, it multiplies first in hepatocytes, then in red blood cells, producing periodic fevers when schizones rupture. In the mosquito, gametocytes mature and continue the cycle. This dual life cycle is the reason our control toolkit spans personal protection, vector control, and prompt case management. If we break human parasitemia or reduce mosquito bites, transmission falls. For Plasmodium vivax, dormant liver hypnozoids cause relapses, which is why radical cure with Primaquine is essential after clearing the blood stages, provided G6PD status is considered.
Case Vignette 1. A 19-year-old hostel student in a forest fringe town presents to the primary health center with high-grade fever, chills and sweats for 2 days. There is no cough or urinary symptoms. On exam, temperature 39.4 degrees, pulse 110, blood pressure 110/70, no jaundice, no neck stiffness. Dr. Joshi, walk us through a community medicine approach.
First, think fever in a malaria endemic setting. Test, do not guess. Obtain a peripheral blood smear, both thick and thin films, or a rapid diagnostic test, that is RDT, which detects parasite antigens. If RDT is positive or smear shows malaria, classify as uncomplicated versus severe. Uncomplicated malaria has no danger signs like persistent vomiting, severe anemia, altered sensorium, shock or respiratory distress. In uncomplicated malaria, treat according to species and local drug policy. For Plasmodium falciparum, artemisinin-based combination therapy, that is ACT, is the standard. For Plasmodium vivax, in chloroquine-sensitive areas, chloroquine clears blood stages, followed by Primaquine for 14 days for radical cure after checking G6PD status. Provide fever control, hydration, and counsel on warning signs. Record and notify the case to the local surveillance system the same day.
Students often mix up diagnosis. What is the neat answer structure?
Right? Confirmatory diagnosis by microscopy or RDT. Microscopy remains the gold standard. Thick smear for screening, thin smear for species identification and parasite density. RDTs are useful for point of care, especially where microscopy is unavailable or at night. Always state, test and treat on the same day.
Analyze mode, levels of prevention. Could you map primordial to tertiary for malaria?
In primordial prevention, reduce ecological risks, urban planning that prevents water stagnation, proper drainage, and housing that limits mosquito entry. In primary prevention, personal protection, long-lasting insecticidal nets, which is known as LLINs, repellents, clothing that covers limbs, and community vector control such as indoor residual spraying, that is IRS, and larval source management, including environmental modification, biological control with larvivorous fish, where appropriate, and periodic anti-larval measures. For secondary prevention, early detection and complete treatment, fever surveillance, same-day testing, and full adherence to the correct regimen to prevent ongoing transmission. For tertiary prevention, prompt recognition and referral of severe malaria for IV artesunate, management of complications like severe anemia, hypoglycemia, acidosis, and renal failure, and rehabilitation after cerebral malaria.
Let us bring in program context for India. If asked, how is malaria being controlled and eliminated nationally, what should students say?
Start with the goal. India's national frameworks target malaria elimination by 2030 through stratified, district-wise approaches. Key pillars are universal access to diagnosis and treatment, integrated vector management, surveillance and response, behavior change communication, and intersectoral coordination. At subcenter and primary health center levels, ASHAs are trained to test fevers with RDTs, provide first-line treatment, counsel on nets, and report cases rapidly. District teams stratify areas based on annual parasite incidence, the API, which is the number of confirmed malaria cases per thousand population per year, and tailor interventions. High-risk pockets receive LLIN distribution and IRS. Low-risk areas intensify surveillance to prevent re-establishment of malaria. For more details, we already have a dedicated episode on NVBDCP. Please refer.
2. Bednet-related exam lines.
1. Long-lasting insecticidal nets reduce human vector contact and provide community protection when coverage is high. 2. Counsel correct use. Hang every night, tuck edges, repair holes, and avoid washing too frequently to preserve insecticide on the fibers.
Students worry about what to write for severe malaria. Could you give a compact, Viva-friendly answer?
Define severe malaria as malaria with one or more danger signs: impaired consciousness, repeated convulsions, severe anemia, jaundice with organ dysfunction, hypoglycemia, shock, acidosis, or very high parasitemia. Management is: give intravenous artesunate immediately, correct hypoglycemia, manage fluids cautiously, treat anemia and acidosis, and give broad supportive care. Once the patient can take orally and is stable, complete the full artesunate-based combination course. In pregnancy, avoid Primaquine. In the first trimester, quinine may be considered where policy dictates, but current practice often prefers artesunate for severe disease. Students should cite national guidelines.
Surveillance definitions pop up in short notes. How would you frame them?
Suspected case is fever without a clear alternative cause in an endemic area. Probable case is clinical malaria with a positive RDT when microscopy is pending. Confirmed case is parasitological confirmation by smear or RDT. Surveillance metrics: annual blood examination rate, that is the ABER, the proportion of population whose blood was examined for malaria in a year, annual parasite incidence, that is the API, and slide positivity rate, that is the SPR. For exams, stress that higher ABER improves confidence in the API.
Quick self-check. Pause and recall. 3 pillars of integrated vector management.
Evidence-based selection of tools, collaboration across sectors, and cost-effective use of multiple methods, LLINs, IRS, and larval source management tailored to local ecology and insecticide resistance.
Nutrition, migration, and housing often surface as determinants. Could you link social determinants with malaria risk?
Poor housing with unscreened windows, sleeping outdoors due to heat, and occupational exposure near forests increase biting. Seasonal migration can disrupt net use and treatment completion. Malnutrition and comorbidities may worsen outcomes. Therefore, cross-sector actions, housing improvement, worker camp net distribution, and employer-linked fever camps enhance health system measures.
Exam tip time. Students are asked, what counseling should you give at bedside for an uncomplicated case?
Say this: take all doses exactly as advised, return immediately for danger signs, persistent vomiting, breathlessness, drowsiness, dark urine, or yellowing of eyes. Sleep under a net every night, eliminate standing water around home, and ensure family members with fever are tested, not treated empirically.
Rapid fire. True or false? Every fever in a high-risk area should be tested for malaria on the same day?
True. Test, do not guess.
Primaquine can be started immediately in all patients, including infants and pregnant women?
False. Primaquine is contraindicated in pregnancy and in infants under specific ages per policy and requires G6PD consideration.
LLINs protect only the person under the net, not the community.
False. High coverage produces community-level protection by lowering mosquito survival.
Before we wrap, Dr. Joshi, could you offer a structured long answer template students can reproduce?
Start with definition and magnitude, add agent, host, and environment, describe transmission and incubation, list clinical features and classification into uncomplicated and severe, cover diagnosis by smear and RDT, outline treatment principles, species-specific regimens, radical cure for Plasmodium vivax with G6PD precautions, intravenous artesunate for severe disease, present prevention across levels, LLINs, IRS, larval source management, personal protection, explain surveillance with ABER, API and slide positivity rate, then India's elimination framework with stratification and community engagement, finish with 2 indicators you would track such as test positivity and treatment completion.
Final 3 take-home messages for your notes.
1. Same-day test and treat breaks transmission. 2. Combine tools, nets, spraying and source reduction based on local evidence. 3. Surveillance is action. Every confirmed case triggers reporting, follow-up, and where needed, a rapid field response. And remember, examiners reward answers that progress from recall to reasoning to real-world application. All the best, and may your community be a low-risk map zone next season.